respiration. How does your brain control respiration? Okay? So we have respiratory centers in the brain stem. You know, the medulla oblongata, that's part of the brain stem that if you have any kind of compromise to it, it becomes very fatal, or will be fatal. All right? The medulla oblongata is going to have the inspiratory center over there. All right? Something in the area where the dorsal roots are. They're going to send motor nerve impulses through the phrenic nerves, and as you remember, phrenic means diaphragm. So these are going to go right to the diaphragm. This is going to contract the diaphragm, and the diaphragm will then move downward, allowing the volume of the thoracic cavity getting larger, which is going to then create a lesser pressure inside to get the air to come in. So contracting the diaphragm, which is what this is doing, is going to cause you to inspire or inhale. Okay? Now, off to the side, just telling you that an overdose of sleeping pills, morphine, or even too much alcohol will suppress this inspiratory center. That's what's going to kill these people, because they're going to stop breathing because the diaphragm is just not going to contract. That's where that comes in. Okay? So that's what the dorsal roots do. The ventral roots of the medulla are going to stimulate when more strenuous breathing movements are needed. Okay? When you're going to need the intercostal muscles to start contracting to get that air out. All right? Most of the time, these are not really going to function in a normal everyday breathing. But when it becomes very strenuous, it's going to kick on the ventral roots, and it's going to stimulate the intercostal muscles and also abdominal muscles to try and push that air out. Right? So people with emphysema are going to have a lot of these ventral roots kicking on because there's a lot of strenuous. They have to use a lot of strenuous exercise or strenuous amount of effort to let out the rest of the air because their elastic fibers just don't work around their lungs. We also have the pons, and if you remember, the pons is the area of the brainstem just above the medulla. Above that, by the way, is the midbrain. So this is the mid portion of the brainstem, which pons actually means bridge, and it bridges the upper and lower portion of the brainstem. Well, anyway, the pons is what's involved with switching the inspiration on and off with the expiration. So how do you know when you inspire, how do you know when to stop inspiring? The pons is going to tell you to do that. It's going to say stop, and then it's going to kick on expiration. Okay? So it's going to do that on and off. It's just switching the inspiration, expiration on and off. That's what the pons is going to do. Okay? Now, what's the main drive? The main drive for respiration is not going to be a decrease of oxygen. You would think maybe that because it's just a common sense to think that, but it's not. When you have low levels of oxygen, that's not going to force you to actually start breathing. What's going to start the breathing is an overwhelming amount of carbon dioxide. The partial pressure of carbon dioxide is the part that is that's what's going to be your driving force to breathe. The amount of CO2, not the amount of O2, at least in a healthy person. Okay, does that make sense? All right, we know this reaction. I know you guys are sick of it, but if I'm drawing it up this much, it would be pretty wise for you to write it someplace and make sure you memorize it, should that happen to appear on one of my exams. Okay? So you should know this reaction. It's going to happen. It's going to appear so many times as you've already seen, and it will do a lot more. Okay? So the amount of CO2 in your blood is the part that is what's going to be the driving force. It's not the amount of hydrogens in your blood. It's not the amount of oxygen in your blood. It's the amount of the partial pressure of CO2. Okay? Now, in people with emphysema, it's a little bit different. Most of you going into the medical field, you should know this. Okay? In people who have emphysema, it's not the amount of CO2 in their blood. They've evolved over an amount of years to realize that they have always like a decreased amount of oxygen in their blood because they have problems getting rid of carbon dioxide, which means that the O2 is going to be very low because there's so much carbon dioxide in the blood. So in people with emphysema, the driving force for them to breathe is not an increase of CO2, but a decrease of oxygen in their blood. It's different. Now, why is this important? How can you use this? All right? You see a patient, if you see, let's say a person, I don't say patient, but a person in Walmart, right? And it seems like they may have COPD, right? Which is bronchitis and emphysema together. So they have some sort of obstructive disease. Let's say emphysema. So they're walking over here, they're hunched over, they're trying to make the thoracic cavity small, right? All the things that you would expect to see in a person who's breathing with emphysema. They're using their accessory muscles. They've got the cannula here hooked up to the oxygen tank that's in their basket. You've seen this in Walmart, right? This is people are living with emphysema. So they're doing this, and if for some reason this person keels over and falls down and they're unconscious. Okay? Now, the first instinct that most people will have is like, put that cannula back on and, you know, put the oxygen all the way, because that's probably why it is they got less oxygen. But this is what's wrong. If that person is emphysema and you start upping the oxygen, what's driving them to breathe? Is it an increase in CO2? A decrease in CO2? An increase in O2? A decrease in O2? What's keeping the emphysema patients alive? A decrease of O2. But you want to go up and turn up the O2. What is that going to do to the person's breathing? It's going to cease it. Because now their body is getting too much oxygen, so they're going to want to not to breathe. You're doing just the opposite. Does that make sense? All right? When you get to respiratory therapy and nursing and these other fields, you'll learn more about that. Okay? So that's what's going on with that. And that's what I wrote in here. So people with COPD, which is chronic obstructive pulmonary disease, it's basically people with emphysema and chronic bronchitis. So we see a lot of patients with COPD. Okay? That's what that is. All right? People who smoke a lot. Yes, they'll probably get the emphysema, but because their bronchioles are so traumatized by all that smoke, the bronchioles and the bronchi get inflamed because of all that trauma that comes to it. So they'll also get chronic bronchitis. This isn't bronchitis from a bacteria. This is chronic. You had it for a long time, months and months, because of all that smoke that's coming in and irritating the lining of these tubules. So usually, these people with emphysema usually have chronic bronchitis also. So we kind of group it all together and say that they have what we call chronic obstructive pulmonary disease, which is COPD. So you're going to see that a lot in the medical realm. You're going to see people with COPD. And yes, one of the top killers in America right now is COPD and emphysema. So you will have questions on this, not on just on my exams, but on your further exams for the rest of your life, because it's such a killer in America. You have a question, Mike?
Yes. People with emphysema, we can give them like more than 2 shots.
You guys see what the doctors, it depends on how bad their emphysema is, but usually when they're on, if they have emphysema or COPD, that they're on oxygen, they need oxygen, but they're on low dose oxygen. Usually like you said, like 2 liters.
It's the same thing for BiPAP. So you can give them the BiPAP mask.
What do you mean the BiPAP?
That's the big mask when they put the mask on the face of the people.
The whole face or just the nose?
No, the face.
Yeah.
Like a mask.
Yeah, the mask. It depends on the situation. That's why you got to wait for the doctor to say, because we have to know that patient, how bad is the emphysema. Usually, if it's the beginning of emphysema, you still want to keep it low, but maybe you could up it a little bit more. And that's why I said you got to know what their numbers are. You got to know what the blood gases are in that person. And you got to do all those checks. It's very individualized. But the rule of thumb is, people with emphysema, what drives them to breathe is low doses of oxygen. You don't want to give them 100% oxygen. You'll kill them. You would think, hey, you're unconscious, but their driving force is the opposite, because it's an adaptive thing that happened over a number of years. So, okay? You'll learn more about it when you get into those fields. Okay? Questions about that? All right. So there's our wonderful reaction, right? So we're going to talk about this after urology in a little more detail, but let me just show you what respiratory acidosis is. It's when we have a pH that's less than 7.35. Okay? Remember, 7.35 to 7.45 is normal. If it's less than that, we're going to call it some sort of acidosis, a low pH. When we throw the word respiratory acidosis, what that's referring to is that you have acidosis, an acidotic state in your blood, due to some sort of pulmonary reason. Okay, there's other reasons, we'll get into those later on, but if you say respiratory acidosis, it's acidosis in their blood that's due to some sort of respiratory reason. Now, if you have an increase of partial pressure of CO2, we call that hypercapnia. That's the fancy word for it, okay? That means we have a lot of carbon dioxide in our blood, okay? Now, this is what happens. You can hold your breath. When you hold your breath, what happens to the amount of carbon dioxide in your blood? Well, if you hold your breath, it goes up, right? Because you're not blowing it off. So you're going to have a state of hypercapnia. You have a lot of CO2 in your blood. So what's that going to do is that the CO2 in your blood is going to get to your brain, and it's going to cause the driving force to breathe. But carbon dioxide has problems getting into the brain, so it has to convert this into this area here. So at the level where the brain is, at this CSF, the cerebral spinal fluid, the carbon dioxide is going to mix with water, and at the CSF level, cerebral spinal fluid, we are going to have carbonic anhydrase here. That will be at this level here. It's going to take the carbon dioxide and the water, change it to hydrogens. Now, hydrogens can get right into the brain itself. It's an ion. It can do that. And this is going to go to the central chemoreceptors in the brain, which are located in the brain stem. And it's going to stimulate the inspiratory center, right? The medulla. It's going to stimulate. So big doses of CO2 crosses into the brain by way of the hydrogen ions. This is then going to go into the brain stem, the medulla, and it's then going to make you breathe. It's going to kick on your phrenic nerves, which lead to your diaphragm. It's going to force you to inhale. That's why you can't hold your breath for very long. The amount of CO2 that's in your blood is going to force you to breathe. We see kids. I mean, I've seen kids, and I don't know if you have, but I've seen like a 2-year-old. And she has this adaptive thing where she wants to hold her breath. I was at a family reunion, and my cousin, his granddaughter, was holding her breath. And he said, should we worry about that? Look at when she's holding her breath. I said, it's okay. She's trying to do it for attention. She doesn't understand that concept. She just realizes, I guess with her psyche, she can do that. Even if she heals over. Now, I'm saying, because I don't want you to think that, oh, geez, he's just holding her breath for that reason. Most cases that I've seen over here, when they hold their breath, they're doing it for attention. All right? Not so much that they fall down, that they can't get, but their body won't allow them to hold their breath all the way because their CO2 in their blood is going to increase, and it's going to force them to breathe. Now, I'm not saying if, let's say, they ate something and something's lodged in their throat. That's why I don't want you to assume that because they're holding their breath, that that's the only reason. There's other reasons. I was watching the child at the time, my niece, so to say, and our cousin, and that's what was happening. We were watching, she was playing, and she just was looking at Grandpa and just, holding their breath, just playing like a game. But that's what I'm saying. Your body won't allow you to, you can do it at home. You can do it here if you want. Hold your breath. You're going to gasp for breath, for breathing, because of this whole situation. Okay? Does that make sense? All right? So it's going to, when you hyperventilate, this will decrease your hydrogens. Okay? So think about it. If I'm going to take this CO2, if I wanted to, and this increases, if my inspiratory center kicks on, I'm going to breathe out more CO2. Hyperventilate. If I'm going to blow off more of the CO2, then technically I'm going to get 30% on this side and 70% on this side. Does that make sense? Because I'm really hyperventilating. I'm taking out all that CO2. But what will happen here is that it's going to reverse. So what's going to happen here is you're going to blow off all that CO2. This is going to go down to balance it so that it becomes 50-50. So here, the hydrogens are going to, when you're blowing off CO2, your hydrogens are going to go down. Does that make sense? This is a question on the quiz. All right? Even if I'm blowing off the CO2, it remains the same, but it's going to force this to go down because it has to make it 50-50 on both sides. Is that clear? You had a question about that, right? Yeah, that's what's going on here. A decrease of CO2 is going to eventually get the amount of hydrogens that go down. If your hydrogens go down, what's going to happen to your pH? It's going to go up. Hydrogens going down, pH goes up. If your hydrogens go up, your pH goes down. Does that make sense? So hyperventilation is going to give you an alkalotic state, a basic state, a non-acidic state, because your pH will go up. Is that clear? Then we have respiratory alkalosis. Alkalosis is when your body is more in a basic state, non-acidic state. This is when your pH is greater than 7.45. Okay? And when we say respiratory alkalosis, we're saying it's alkalosis that's due to some sort of respiratory reason. We could say that someone is hyperventilating. Right? As I just showed you over here. If you're going to hyperventilate, you're blowing off a whole mess full of CO2. What's that going to do to the amount of hydrogens? As that's emptying, what's going to happen to the hydrogens? Is it going down or is it going to go up? It's going to go down. Right? If you're going to have, if you let out all the CO2 here, not all of it, but a big percentage, you're going to have 30% over here now, it used to be 50. Net-wise, you haven't really touched this yet, but you'll have 70% of the products here. Because we got rid of the CO2 here. So now, this is not a stable thing. So the amount of CO2 that's going out, we got to have this balance. So therefore, the reaction wants to go this way to replace the CO2 that we just blew off. Which means that the hydrogens are going to decrease until we can get it back to 50 and bring us up to 50%. When you do that, your hydrogens are going down. What does your pH do? It goes up. All right? Does that make sense? This is the theory of why someone is hysteric. Calm down. You're hyperventilating when you're hysteric, right? You're anxious. So what's one of the things that someone may say? One of those, what do they tell you to do when someone is that anxious and they're hyperventilating or hysteric? What are they going to say? What's that? take a deep breath, but they're not listening. So what else would you do? What did it give you so that you could blow into? Paper bag. So here's where the theory comes in. You put the paper bag there. What are you blowing out? CO2. So if you're in a bag, what are you going to breathe back in? So you're breathing back the CO2. So in theory, this should go back up and should fix this. Does that make sense? In theory. Does it actually work? I don't think it actually works. I think what it does is that they're actually concentrating on their breathing. So they're conscious about what's happening, and they can say, oh, so they don't have to worry about the problems that they have that caused all this. So they're concentrating on it. Does it help? I would love to see a study that actually says it, but I haven't seen one. There may be one out there, but I haven't seen one. But that's the theory of why you put a paper bag in front of them so they could breathe in that CO2. Does that make sense? Okay? Yeah, that's what I mean. That's what I think it is, a distraction from what's causing them to become this alkalotic state, so they can breathe in.
Like when people are really nervous, they say, oh, just run water with sugar. That doesn't actually do anything.
Nah,
but because the person believes that it will calm
placebo.
down, and they'll be like,
Yeah, it's a placebo effect.
Yeah.
So it's, unless there's a study, and that's something if you guys want to get into studies and stuff in your future and stuff, that's something interesting to do. But you got to force someone to hyperventilate, right? And you could do that. You could, and then you can see what a brown paper bag does. That's an interesting, study to do. So if you hypoventilate, you're going to increase the hydrogens, right? If you're going to hypoventilate, so now let's say you're not going to blow out all this. So that means your CO2 is going to increase. So if it was normally 50%, and this was normally 50%, but now you're going to hold in by hypoventilating. You're not going to breathe it all out. So now this is going to increase. Does that make sense? You're going to keep it all in you. So this will go up to 70%. This is down to 30. Right? Does that make sense? So what will happen is the reaction is going to go this way. And what we're going to do is the amount of hydrogens here are going to increase back to 50. Does that make sense? To get it back there. We're putting more ingredients here. The reaction has to go that way because you're not blowing it off. So if you hypoventilate, you're going to increase the hydrogen ions in your blood, which means what's that going to do to your pH? Increase, right? If you increase hydrogens, I'm sorry, you're right, I'm sorry. If you increase hydrogens, then your pH will go down. Okay? Questions about that? All right. You could do this on your own. It's just follow all the steps. It's everything we've been talking about, chemoreceptors, and what's it do to acidosis and alkalosis, and you can see how it gets restored and stuff. All the stuff we talked about. Other effects of gases, carbon dioxide. Okay? We have central chemoreceptors. This is where the partial pressure CO2 crosses the blood-brain barrier, as I just showed you. We have carbonic anhydrase at the blood-brain barrier, and it's going to convert the amount of CO2 into ions. This will then go to your inspiration center of your brain stem and causes breathing. We also have peripheral chemoreceptors, and these are more or less in your chest area, where your aortic arch is and carotid areas. The amount of the partial pressure CO2, when that increases, these will also turn those on. And when this happens, it triggers more ventilation quickly, all right, more quickly than the central. But these don't usually kick on until the central ones are used up. Right? So these are the peripheral chemoreceptors are for people who are long-standing in areas where you're going to have a lot of CO2. Okay? Oxygen, there's usually a little effect, as I just showed you, at least in a healthy person. With emphysema, that does affect them, but for us, not so much. But we could have an area where we have chronic hypoxia. Hypoxia is a decrease of oxygen in an area that you're breathing in. Okay? This can significantly change stimulate your ventilation, right? If you have less oxygen just out there. And people with emphysema, pneumonia, just can't get the oxygen in there. Okay? So this is just showing you where the peripheral chemoreceptors are. Like I said, they're on the aortic arch, and you also have them on the carotid, right where the carotid, internal and external carotid arteries branch off, right at that bifurcation. Now, I just want to talk about oxygen excess for a moment. You put too much oxygen in the person's body. Can that cause problems? Yeah. Okay. We get oxygen toxicity. Pure oxygen that you breathe in at 2.5 atmospheres or greater, that will cause problems. It damages the nervous system. It destroys the enzymes. Because what it does is it actually, if you're learning chemistry, it actually creates these free radicals and hydrogen peroxide. H2 O2 is hydrogen peroxide. When it does this, it's going to chemically change things in your body, and that can cause problems. As I said, it destroy enzymes. It could damage your nervous system, lead to seizures, coma, and death. So that's why we just can't sell oxygen things just for the heck of it in a drugstore. There needs to be a prescription for it. A doctor has to prescribe oxygen because if you give too much in the wrong hands, you can kill someone. Okay? We have something called the hyperbaric oxygen chambers. Okay? You've probably seen this or heard about these. We call it HBO for short. We do use them. We increase the pressure of oxygen that you could breathe in. Now, there could be some benefits to this when used properly. If you remember, oxygen, 90% of oxygen is carried through our bloodstream on hemoglobin. But 2% of oxygen actually goes and gets dissolved in the plasma of the blood. Only 2%. Okay? But we could, if we increase the pressure of oxygen that you're going to breathe in, we could put more oxygen dissolved in the blood, in the plasma, which means that you're going to put more oxygen in the person's blood. Does that make sense? We're increasing. We're going to have them breathe in higher pressure oxygen. We call it a hyperbaric oxygen chamber. And basically what it is, it kind of looks like a big dome cylinder that the person actually is in. And they pressurize the oxygen in there, and you're breathing it in. You're in there for a few hours or so. Depends on the reason why they're in there. My father was in this. He lost his toe because of diabetes. And if you know anything with diabetes, the microcirculation gets destroyed because of all the high doses of glucose that's in the bloodstream. So you have this microcirculation, even the smaller capillaries, they get loaded with glucose, so now it blocks any blood flow to go to certain areas. Now, the microcirculation will go to nerves because the nerves are so small. So that's why diabetics, they don't have much feeling on the bottoms of their feet because their nerves have been destroyed because of the amount of glucose. The microcirculation has been destroyed because of all this heavy doses of glucose. So we have problems. My father had to get his toe amputated because of gangrene due to diabetes, and the healing was taking too long. But diabetics, that's the reason why, because there isn't good blood flow going to these, to let's say, the distant areas, whether your toes or your fingers. So they have less blood flow going there, which means you're going to have less oxygen going there. So if you put a person who has a situation where the healing is just taking taken months and months to heal, if you put them in a pressurized area where there's oxygen, or let's say a hyperbaric chamber, you're going to give them higher doses of oxygen that can eventually get to that area. Instead of just the 2% going there, we're going to make sure that maybe 10% goes there. And hopefully, usually they'll know, at least in a week's time, if you're actually going to get a good response to this or not. And he luckily had a good response to it. But if it's so darn blocked, no matter how much oxygen you're putting into the blood, no matter how much pressure you're putting in it, it's just not going to get there. But my father had a nice, blood supply there. He just needed more oxygen to get there to speed up the time for healing, right? More oxygen going there, that means the cells could actually get activated a little bit better with that high dose of oxygen. So that's what happens with a hyperbaric chamber, okay? Like I said, it's used to expedite wound healing in people with diabetes. That's one way to use it. Breathe in high pressurized oxygen, dissolves more than the usual 2% of oxygen in the plasma, okay? And hopefully that extra amount of oxygen will be able to go to that healing area and take on it, so that cells can take on more of that oxygen, plenty of glucose over there, and then the ATP will be made, and you could actually stimulate the body to heal faster. Okay, does that make sense?
Let me ask you, then, how come more diabetics are on oxygen?
Because you can't put too much on. This is for the healing process. Yeah. Does that make sense? It's only for the microcirculation.
So it wouldn't help prevent any,
No. No. It's only when there's something there. It's not to prevent anything, it's actually to treat something. And like I don't know the percentages, but like I said, my father was lucky that it was able to speed up the process. He got a good response from it. So that's and that was my idea for my father to get that done. I talked to the doctor, the podiatrist, and I said, well, have we tried doing like a hyperbaric chamber? He's like, that's not a bad idea. He might be a candidate. I said, let's try it. See if insurance. That's the other thing you got to worry about too. Is see if insurance could cover it. They would cover the first 3 if there's good response. Then he was able to do. It was like I think he was in it for 2 hours a day for 3 days. So Monday, Wednesday, Friday kind of thing. I think he was on it for like 4 to 5 weeks. It's relaxing. You're just sitting there. You don't sense any kind of pressurized oxygen. You just feel like you're breathing in it. That's all it is. It's very expensive, and not all hospitals have it. You got to make sure that the hospital has it. But it's another resort to try and speed up the process. Okay. So just keep in mind, oxygen is a drug. It's a medication, and it needs to be prescribed. We also learned this, that it used to be treated for premature babies. They thought that premature babies in the 50s and 60s, if you give them a high dose of oxygen, that would speed up the breathing process. Was it really? Actually, it started because they had high doses of oxygen, it started affecting the brain. And that's how Stevie Wonder became blind. He was premature, they gave him a high dose of oxygen, and that was one of the side effects of it, and he was blind. So he wasn't born blind, it was because, but that was the gold standard at that time. They didn't do anything wrong. That's what you just do with premature babies. But the high dose made him blind. That's what happened. Okay? So we don't do that anymore, the premature. There's other ways that we could, now we have ultrasounds and things we could actually, and we have certain other blood tests that we could do to see if the lungs are not mature. We give medication, steroids to speed up the maturity of the lungs. So there's other ways that we have things now, but in the, I don't know when he was born, 40s or something like that, but that's what the gold standard was at